Today I'm going to talk about the mental health of children. I'm going to begin with talking about some of the building blocks of mental health for children, and then talk specifically about mental health problems that some children might face and generally what we might do about it. Next, please. Attachment is one of the building blocks of mental health. What is attachment? It's the caregiving and seeking relationship between individuals and how we communicate in this interaction. It's a biopsychosocial response process that begins to develop from birth and is activated when any of an individual is stressed and seek help, care and protection. In other words, it applies to us all. If we seek help or need help and care and protection, our attachment processes are activated because we seek help in relationship with another. Resilience is the process of rebounding or springing back. It's the ability to recover readily or resist being affected by a stress, a setback, or an illness. And resilience is also another fundamental building block of mental health. Next, please. So what is mental health? Well, it's a state of well-being referring to our emotional, psychological and spiritual health and how we feel about ourselves and how we adapt and function to the best of our ability in the world around us. And if you think about that for a moment, you can see how it determines how well we work, how well we socialise, how well we love and play and be creative. In fact, it determines all of the aspects of ourselves as human beings. It impacts the intellectual, social and economic capital of a community. Therefore, for the whole community, mental health is vital to not only our individual, but our community well-being. Next slide, thank you. Well, now, how does attachment mediate resilience and mental health? Well, firstly, the development of an early in life secure attachment experience occurs when the infant experiences a predictable relief of distress, of discomfort and hunger. The baby's hungry, the baby cries, and fairly regularly the baby then gets food, gets mother's milk, and that's a great relief. And that encourages the development of a secure attachment. The baby learns to feel safe, cared for, and protected. How does that differ from an insecure attachment? Well, an insecure attachment experience develops in the setting of unpredictable or insufficient care and nurture, or insufficient relief of stress, and is therefore associated with a range of adverse infant experiences. In other words, the infant starts to experience distress, which is not relieved and can become relentless. That leads to an insecure attachment. Next slide, thank you. This is a little difficult to follow this slide, but in the middle, we have a depiction of what happens in our brain when we're stressed. Stress has an impact on the brain and our body's function. Stress works through the brain out into our body through our nervous system. It affects our hormone production, and it even affects things like our immune system and our general health. On the left side of the slide, we can see what happens if the attachment is secure. A secure attachment leads to the best brain development that's possible in that child, given other things. It leads to a balance in how the child works. It leads to the development of social and language and organisational and personality characteristics and skills development. If we're securely attached, we develop to the best of our ability, for example, socially. A secure attachment improves our ability to regulate our emotions into the future and helps us to calm down and soothe ourselves, which is a very important feature we need when we're adults even. It helps us to manage stress and is the foundation of resilience. Interestingly, a secure attachment also magnifies the possibility that we will be in good physical health. It has an impact on our health generally. What about an insecure attachment? On the right-hand side of the slide, well, this leads to dysfunctional brain development and instability. It can adversely affect social development, our personality development, our daily living skills, our learning skills, and it can even set the scene for the development of major mental illness like psychosis when we're adults. An insecure attachment has a big impact on the regulation of our emotions. If we're insecurely attached, we can learn to be helpless, and that leads to depression. Our anxiety levels rise, and so that leads to a number of mental health problems like anxiety and panic. Insecure attachment also impacts our body. We can have somatic symptoms like heart flutters or problems with our breathing, and that can lead to health problems. And finally, insecure attachment can set the scene for behavioural and stress decompensation. In other words, if we have an insecure attachment and we might be stressed by an awful experience like a bushfire when we're 25 years of age, that can lead on to a cascade of stress arousal problems and the formation of a post-traumatic stress disorder. And finally, an insecure attachment can lead to poor health. So you can see how attachment plays an absolutely vital part in the establishment of a good start to life. Now, what are the barriers to attachment? What gets in the way of secure attachment? Let's look at the next slide. Now, there are a couple of infant or child risks that are barriers to secure attachment. Abnormalities in the pregnancy or genetic abnormalities in the baby, the use of fetal alcohol substances, that is if the baby drinks alcohol from the mother when it's still in the womb, cigarettes and things like that. Trauma during the birth period, prematurity, a very complicated delivery in which the baby's brain is stressed by those traumas. Children born with developmental delay, in other words, where their language might be delayed or when their intellectual abilities are not as much as they should be. Other infant risks or child risks are chronic illness in the child, children who have chronic illnesses such as epilepsy and so forth. Other barriers to attachment is if the child has disorganised behaviours. So, for example, they may not sleep very easily or feed very easily, or they've got motor skills problems. Some of these children can be also very emotionally reactive, and that can lead to insecure attachments because the mother or parents don't know quite how to handle a child who seems to go off like a firecracker every time they look at him or her. Certainly, persistent and overwhelming stress placed on a baby leads to insecure attachments and can even lead to changes in parts of the chromosome or the gene, which may have lifelong effects on the baby's development. Next slide, please. There are also some environmental factors which are a barrier to secure attachments. There are a number of family risks. For example, if the parent themselves has experienced an insecure attachment and really doesn't know quite how to safely attach to their baby. If the mother has experienced mental illness during the pregnancy or in the postnatal period, for example, postnatal depression. Or if the father has some mental illness during the pregnancy and early childhood time. Poor parental behaviour, such as what might lead to abuse or neglect or substance abuse in the parent or parents. Certainly marital conflict, and in its most extreme form, domestic violence, can have a very big impact on standing in the way of a secure attachment. There are a number of important social risks too. A very disadvantaged community, for example, where the income is low, poor housing, few services, homelessness, unemployment, being a refugee or an asylum seeker, particularly in detention, and experiencing cultural isolation, alienation, and discrimination. And of course, in my acknowledgement of the Indigenous people of this land, I've already mentioned the stolen generation as being a risk, a barrier to secure attachment. Mind you, if you look at this list, you see there are a number of things that we can act upon. We can act upon providing housing for those that don't have it. We can act upon isolation, alienation, and racism. We can act upon and try and help with alleviating domestic violence. Next slide, please. Well, how do parents promote attachment and build mental health? Well, this list sounds simple, but maybe it's not so much, but they all act together to build better babies and better mental health. Provide a safe and secure environment. Provide predictable and sufficient sleep, healthy food, and active interaction for your children. Be affectionate and provide supportive care of infants and children. Don't rush in, watch, think, what does my child indicate by their behaviour? Wait, think about it and wonder how might you respond. Provide opportunities for play, for recreation and sport. Provide organised social and learning activities, not just in school and preschool, but also in things like clubs and community events. Provide safe social contact outside the family. Provide good, affirming relationships with an adult outside the family. In other words, it's good for children to get to know safe adults that are approved by the parents, where the child can have some experiences of gradually moving into the community. Provide supportive attention from caregivers. Praise and focus on strengths. Reward effort and autonomy. In other words, don't put children down. Build each other up. Provide opportunities to develop communication skills and language development, for example, in social activities for children and playgroups. Next slide, thank you. Well, how as a, how as a community can we promote attachment? Well, we can promote attachment by providing a safe community environment and adequate housing for families. We can provide safe community facilities for child activities and play with peers. And you can see a lot of local government are very active in that space. We can provide quality antenatal and postnatal maternal and child health care. And here, at least in Victoria, we have very strong maternal and child health care, and that really helps. This is an important one, this next one. Provide 2 years of universal quality preschool education. That really helps children develop. If they're going to preschool, that is a good one. We can build parental capacity to provide a secure attachment and safe and consistent care with the generally and universally available opportunity for parents to participate in parent education and skills training programs. These don't blame parents, but they build parents up and show them how to do it better. Because after all, what school do you go to teach you how to be a parent? Now, there are a number of these programs. For example, there's the BEAR program, which Mental Health Foundation supports. There's Parenting with Feeling. There's the Triple P suite of offerings. And there's Tuning Into Kids, for example. These are all available on the website and can be done usually online or by attending groups or a therapist that will offer them. Next slide, please. So if you like, we've been looking at the building blocks of mental health in children, but not all children are mentally healthy. And so I want to now look at how our clinically significant mental health problems manifest in children. Now, they're not uncommon. At least 7 to 10% of children at any one time have a clinically significant mental health problem. They're not just fussy or a bit naughty, they are really troubled and disturbed. These take the major forms of: some children are disturbed in their behaviour. We call that antisocial behaviour or an externalising disorder. Up to 5% of children have those problems. Some children are troubled with their emotions and feelings. We call that an internalising disorder. Some children have a mixture of psychological problems and physical illness. For example, they might have a hearing difficulty and associated problems with that. We call these somatoform disorders. There are some rarer conditions like autism spectrum disorder and intellectual disability, or even more rarely a childhood psychosis, and they affect somewhere between 1 to 3% of children. So they're still not that rare, but they're rarer than the other conditions I've spoken about. Let's look at some of these more specifically. We can move on now to anxiety. What are the symptoms of an anxious child? Well, they become distressed and agitated, for example, if they're separated from their parents or home. This may spill over into becoming school refusal, where they're so anxious they can't go to school. Their anxiety can be pervasive and fill their whole life with fearfulness. Sometimes it can make them extremely restless and irritable, or they may retreat and become timid or shy and withdraw socially from family and friends. They may develop what we call phobias or terror of an object, for example, like dogs or the thunder or something like that. Sometimes they'll have problems in the feelings in their body, so they may have headaches or stomach pains or palpitations. Their sleep is usually disturbed with difficulty getting off to sleep, and they may have nightmares which trouble them and make them unhappy. Their concentration can be reduced, and at school they may be distractible and have learning problems. And some children may, in their play, repeatedly play out the theme of their worry in their play. So they can have quite a lot of symptoms. Next slide, thanks. What contributes to these anxiety disorders? Well, a number of family factors can. We know that if there's an anxious child, there might well be an anxious parent. These parents may in fact overprotect their child. It's very important for parents to protect their children and keep them safe, but you can do too much of it. And sometimes that inhibits the child and stops their development and might make the child anxious about stepping out into the world. The parents may suffer from a mental illness themselves, such as depression or anxiety. Quite often there can be family stresses as well, for example, marital conflict or a parental illness, or there might even be something as serious as child abuse. Quite often there's a family history of anxiety too. How do we manage children with anxiety disorders? Let's look at the next slide. Well, there are a number of treatments apart from parents providing support and reassurance to children. There's something we call cognitive behavioural therapy, which is a psychological treatment in which the child, either in a group or individually, talks with the therapist about their anxiety and develops strategies to manage it. Sometimes the family meeting all together can help, particularly where the parents can get help to stop being overprotective, but to still support their children positively. The parents can go for treatment for their anxiety or depression to a mental health service or clinic, or to their general practice or a therapist. Sometimes psychotherapy of the play therapy type can help anxious children as well. Teacher support. Sometimes we help anxious children by providing support and guidance and education to the teacher, so the teacher can be tuned into that child and know how to help. Very occasionally, we might suggest medication. This must be done only as an adjunct to psychological interventions, and again, delivered by someone who's an expert and who knows how to manage medications and what the side effects are, and to monitor outcome. Next slide, thanks. Here is an example of someone called Anna, who was refusing to go to school and had not been able to go to school for nearly 3 months. I did her a drawing of a worried, calm thermometer. At the top, you can see a very worried girl, and at the bottom, a very calm girl. When I asked Anna to rate herself as to how she felt most of the time, she scribbled over the very top of the thermometer, indicating that she felt very anxious and fearful. Later on, during the session, you can put the next slide on, thanks. I did a picture of a little girl asleep in bed and said that, Anna, this is you, you're having a bad dream. Draw me a picture of your bad dream. And when I talked to her about it, she said it was of a monster who was attacking her and making her feel very sad and worried. And I said, what sort of a monster was it? And she said, well, it's a mother monster. And I said, well, what does the mother do? And she said, oh, she throws pill bombs at me. And there are the pill bombs attacking Anna. And I said, I wondered if perhaps Anna was very worried about her mother was at the moment. And she said, yes, she was very worried about her mum because her mother was also crying a lot and wasn't well. When I showed this to the parents, the mother admitted that for the past 3 months, she'd been very depressed and sad for all sorts of reasons and had just started to have treatment with some medication, which was helping her. She then understood what was worrying her daughter. And in fact, her daughter was not afraid to go to school, but was afraid to leave home because she thought she should stay at home to keep her mother safe. It had a good outcome, that intervention. Next slide, thank you. This is about depression, which is another internalizing disorder that can affect children. Children who are depressed, and I must emphasize here, children can be depressed. There used to be a view that children didn't have emotions and feelings, but we know that even little children can be sad and depressed. Their mood can be persistently depressed. They experience unhappiness. And most importantly, most depressed children also become highly irritable. They lose interest in play and friends. They lose energy and concentration. Their schoolwork deteriorates. There's loss of appetite sometimes or no weight gain. Their sleep is disturbed. Sometimes they might develop thoughts of worthlessness and suicide, but actually suicide attempts are rare before the age of 10, but still must be taken seriously. It's not a fact that if the child says they're feeling like they want to be dead, that they're not going to do it. You must seek help for those children. They may have somatic complaints, and they may have anxiety and conduct disorder and other problems like attention deficit hyperactivity disorder as well, and eating disorders or substance abuse. Next slide, thank you. Here's a happy, sad thermometer and a calm, grumpy thermometer, which can help the child express whether they're feeling irritable and whether they're feeling sad. And children who are depressed usually rate themselves as sad and irritable. Next slide, thank you. What are the family factors that contribute to depression? Family stress does, such as having an ill or deceased parent, family conflict, and parental separation. Usually the child has experienced repeated experiences of failure or criticism. If you criticize your child constantly, you know, the child comes home with an exam score of 98 and you say, oh, what happened about the 2%? Why didn't you get 100? If that's the constant experience of a child, they will start to feel worthless and they will spiral down into a depression. Build each other up, reward achievement. And there's often a family history of depression as well. How do we manage depression? Next slide, thank you. Well, we manage depression, again, through psychological treatment called cognitive behavioural therapy. Family therapy can help, particularly managing family grief and conflict, and play therapy, again, can be very useful. One of the most important ways we manage depression is to work with teachers to help the child experience success at school. In other words, they get a ducky stamp and a reward for trying to get their maths test done, rather than criticism for failing to finish it. Sometimes antidepressant medications are useful, particularly in older children and adolescents, but they again should only be provided when psychological treatment and family help is provided. And again, it needs to be monitored, side effects need to be assessed, and there needs to be follow-up to see if the treatment actually works. Next slide, thank you. Here is an example of a young child's work in cognitive behavioural therapy. This young boy was very depressed and made a lot of negative self-statements. And what he's done there is he's been encouraged to write his negative self-statement down on the left. And I'll read it out, although the spelling's cute, isn't it? I don't like school because I never get anything right. I don't want to wake up and be alive. So that statement is then challenged by the therapist, because there are always positive things we can say about ourselves. And on the right, he eventually comes up with the positive statement. Mr. E, that's a teacher, can help me. I can read to the preps. In other words, he's saying, when I read to the preps, that makes me feel good. When I awake, that is when I wake up, I can play football and have a Slurpee and visit Gran. In other words, there are some positive things I can do. Next slide, please. What about other sorts of mental health problems in children, particularly in the externalizing type? These mental health problems, one example is attention deficit hyperactivity disorder. It speaks for itself, really. This is not just busy little children, but these are really disordered children. Their symptoms have to be developmentally excessive, that is not what you'd expect for a child their age, and pervasive, that is it affects all aspects of their life. They can't pay attention, they're careless, they can't listen, they don't follow through, they interrupt and cannot wait their turn, they talk excessively, they avoid difficult tasks, they fidget, they can't sit still, they're overactive, they're forgetful and distractible and disorganised and impulsive. And some of them, about 20%, also suffer from anxiety and depression. What can we do about attention deficit hyperactivity disorder? Next slide. No, sorry, I'm not quite onto the treatment yet. There are some associated difficulties with ADHD. Usually they have a very difficult temperament. Many children with ADHD have learning disabilities with problems with their short-term memory. Often there's a history of pregnancy and perinatal complications, and some children have problems with their general nervous system. For example, they might be clumsy or have a tremor. There's often a history of family conflict and parenting problems. Now let's move on to how do we manage ADHD. Well, a lot of things help. The parents attending parenting skills training workshops, that can help the parent manage their child more effectively. Educational programs for learning disabilities are very important, and these children need individual learning plans at school. You can alter the environment to reduce distraction. In other words, don't have a playroom full of thousands of toys, but just provide a few toys at a time. Divide tasks into small steps and channel energy. There are a number of behavioural management approaches to managing antisocial behaviour, and parents can learn these. Family therapy can help, again, particularly where families are in conflict. These are a group of children who can also respond very effectively to various medications. These are called stimulants mostly, and this must always be in consultation with a specialist. Let's look at the last condition I want to talk about, and that's conduct disorder. Children with conduct disorder have persistent disruptive antisocial behaviour. They're hostile and aggressive. They're often vandals. They truant from school and lie and steal. About 20% of them act alone, and they're the biggest worry. They continue to often have very severe difficulties. Often, mostly about 80% of children with conduct disorder act within a group. They get, if you like, a stimulus from the group doing the same. They can be hyperactive. Many of them have learning problems, and some of them, about 20%, also have depression. And that's important to know because you can treat the depression. And those children can actually, when they get older, be at risk of suicide, those that have had conduct disorder and depression. And a number of children can run away from home. Next slide, please. What contributes to conduct disorder? Social disadvantage definitely does. Large family size, inconsistent and hostile parenting, particularly father's role, parental conflict, children growing up in institutional care or foster homes. And that's not just because it's the foster home, it's because of what led the child to need to be fostered. Parental mental illness and parental criminality, child abuse and family violence, and being part of an antisocial peer group all contribute to conduct disorder. What can we do to help? Let's look at the next slide. The management involves early intervention. Get in early if children are starting to misbehave, usually with parenting skills training. Create opportunities for success, for example, in sport and recreation and in things like martial arts. Success achievement in educational programs. These kids are often put down and really criticised for being naughty rather than using whatever thing they do that might be good as a reward. Comment. Behavioural treatment from a therapist where social skills are taught, and family therapy for conflict and conflict resolution. Now, I'm going to, in fact, skip the next 3 slides, thank you, in which we were going to talk about stress and stress management, but we've been, next one, thanks, next one. Okay, we'll stop there. We were going to talk about stress and its impact on children, but I think that's been clear as I've been talking, and maybe that might be the subject of another webinar. But there are some helpful responses that we as a community and as families can provide children to prevent mental health problems or to help them be treated. Firstly, provide structure, routine and predictability. Limit unnecessary changes and prepare for transitions. Remove or modify environmental stresses that upset or confuse. Very important at school and elsewhere, tackle bullying, and this is online as well, and provide an assurance of safety for children. Provide pleasant activities that encourage supportive social contact. Provide safe choices. Promote a healthy diet, exercise and sleep, and I can't emphasise that one enough. And always reward achievement. Congratulations is easy to say and has a big impact. Promote self-esteem. And above all, if you think a child is having mental health problems and it's getting worse, facilitate contact with mental health services, and that can be done through your GP, online through organisations like Kids Helpline, our own Mental Health Foundation Australia helpline, counselling services and support treatment programs. Next slide, thank you. Children grow up in families and we build our resilience and mental health by having good attachment and loving care, affirming relationships, good social contact, a good inheritance and health, and the opportunity to develop play skills with organised activity.